Good morning. We'll go ahead and get started. I'm obviously not Dr. Roman. He's out of town. So I'm going to allow Dr. Lederer to introduce the speaker, who is from the Nephrology Division. But prior to that, I wanted to remind everyone that on Saturday, March the 4th, there will be a Louisville NASH seminar in the CTR building, rooms 101 through 102. The registration begins at 7:30, and there's a continental breakfast. And if anybody's interested, please contact the SC Liver Research Consortium, and they'll be glad to send you information. So if you're available and interested, it should be a really interesting and robust conference. So with no further ado, I will allow Dr. Lederer to introduce our speaker.
I don't think it's going to be a spoiler alert if I tell everybody that I'm a physiology fanatic. And one of my most favorite talks with the residents and the students is about the wide range of urinary dilution and concentration, which I just personally find absolutely amazing. Most people don't, but I just want you to know that it makes your life a lot easier, the fact that your kidneys can change the concentration of the urine by 30-fold. So I'm really delighted, absolutely delighted, to introduce another physiology fanatic, Dr. Jeff Sands from Emory University. Jeff and I have been friends for a gazillion years. We have served together on committees for the American Society of Nephrology. We attend mutual meetings, the Southern Salt and Water meeting in Sarasota, Florida in December. That's a great one. And many of the American Physiological Society meetings as well. Jeff did his undergraduate and medical training in Boston, residency in Chicago, and spent some time at the NIH before completing his renal fellowship at Emory. And then after he completed his renal fellowship there, he stayed. And is now the professor of medicine and the division chief for nephrology at Emory. He has been continuously funded by the NIH for the last few decades and has chosen as his area of interest the mechanisms of urinary concentration. He has made many seminal discoveries in the properties of water transporters and urea transporters, and so it is my great pleasure to ask Dr. Sands to come to the stage. He has also just been elected as the president of the American Physiological Society as well. Jeff, congratulations.
Thank you, Eleanor, for that very kind introduction. It's certainly an honor to both be here. It's my first time in reality in Kentucky and certainly in Louisville, and to be introduced by the president of the American Society of Nephrology. So thank you again for that kind introduction. What I'd like to talk to you about today, as you can see from the title slide, is a fairly rare disease, a disease called nephrogenic diabetes insipidus, not to be confused with diabetes mellitus. And you may wonder, why did I pick this topic? Well, rare diseases often give us insights into basic physiologic properties and how the kidney and how an organ can work. But even more so, what I hope you'll get out of the next hour is to see how, by studying physiology and studying the mechanisms by which certain processes occur, it can lead to potential new insights and roads to therapy that ultimately may benefit these patients. So even if you don't remember much about nephrogenic diabetes insipidus, I hope you'll take away from this the fundamental importance of physician scientists in contributing to the advancement of knowledge. So that's my editorial. The learning objectives are to review the physiology of the urine concentrating mechanism and transcellular water transport. We'll review nephrogenic diabetes insipidus and review the dysregulation of water channels that occurs in other common clinical conditions that many of you are seeing every day. And unfortunately, I have no disclosures of any kind, relevant or irrelevant. There are many clinical conditions that are associated with abnormalities of water balance. And I'm sure as you look over this list, many of these are conditions you're probably seeing in your clinics or on the wards. In adult medicine, lithium therapy is the most common cause of an acquired form of nephrogenic diabetes insipidus. Electrolyte abnormalities can do it. Prolonged hypokalemia for a period of 2 to 3 weeks. Low protein diets, hypercalcemia of even a few days can do it. The one we'll focus on today is diabetes insipidus. Near the end, I'll show you some data on normal aging. And yes, for some of us, this is becomes more of interest with every passing day. Diabetes mellitus and adrenal insufficiency. So we'll start with the clinical case. This is a 53-year-old white male who's admitted with a neck cancer, has a long history of bipolar disorder. He's been treated with lithium for 600 twice a day, and post-op he gets the usual post-op fluid of D5 half normal saline, because half normal saline is almost always half right and half wrong. Your serum sodium goes up to 151, and then they allow the patient to drink. 24-hour intake is 7 liters, with the IVs 10 liters, and he's putting out 8 liters. So obviously profoundly polyuric and polydipsic. Post-op day 3, sodium's 145, urine output is still 5 liters. At this point, there's a repeat history taken. I don't know if that means they got an internal medicine consult at this point, but anyway, a history was taken, and it turns out this patient had a several-year history of polyuria and polydipsia. He was awakening 3 to 4 times per night to urinate and drink water. And what is very typical of this type of disease presentation is that the onset was insidious. It didn't all of a sudden happen that the patient one day was waking up 3 to 4 times a night and drinking. It was just gradual, so it was hardly noticed by the patient that anything had changed. And thus he really didn't report this in his initial history until you pushed him on it to get more details. And this is an actual case. This was published over 20 years ago for anyone who wants to look it up. So how do we approach this? And so we're going to start with my view of the nephron. And my view of the nephron is focused on the urine concentrating mechanism. To orient you, there's the cortex, the outer medulla, and the inner medulla. You have the glomerulus here and the proximal tubule. And while 60 to 80% of the glomerular ultrafiltrate is reabsorbed here in the proximal tubule, it's all done isosmotically. There's no separation of salt and water. So for the purposes of the urine concentrating mechanism, the glomerulus, the proximal tubule, and really the entire cortex is irrelevant. When I say this, the nephropathologists have a stroke because that's what they care about is the cortex. But for this, what we care about is the medulla. And the main player here is the thick ascending limb. This is the site, this is the location of the sodium-potassium 2-chloride cotransporter. This is the cotransporter that when you give a patient a loop diuretic, you're inhibiting this transporter. The net result of this transporter, since the potassium recycles, is to move salt from the lumen of the thick ascending limb into the interstitium. This accomplishes 2 critically important tasks all at once. You have now diluted the fluid in the thick ascending limb lumen, so when it comes up here to the cortex, it can be as low as 50 milliosmol. And at the same time, you've taken that salt from here and added it to the interstitium, which by countercurrent multiplication can increase the osmolality to as much as 1,200 down here in a person, 2,000 to 3,000 in a rat, 3,000 to 4,000 in a mouse, 6,000 in a chinchilla, and some desert species even to 10,000. But because this transporter gives you separation of salt and water, dilute fluid here, concentrated fluid here, you've now set up the potential to excrete either concentrated or dilute urine. In much of the literature, this segment is referred to actually as the diluting segment because of the production of dilute tubular fluid. It also is referred to as the single effect because with one effect, you've separated the salt and the water. Now, in conditions in which you need to excrete dilute urine, say I see many people are drinking coffee and water and other beverages, so by the end of this hour, you're probably going to have very dilute urine. You've suppressed your endogenous ADH, antidiuretic hormone, also called vasopressin. It's two words for the same thing, but you suppress it, your posterior pituitary doesn't release it, the collecting duct becomes virtually water impermeable, and this dilute fluid here is simply excreted as dilute urine. But before you start drinking all that coffee this morning, unless you were on call last night, you were probably making highly concentrated urine. In that case, your endogenous ADH or vasopressin levels are high. They act on the water channels, aquaporin 2 in the apical membrane, 3 and 4 in the basolateral, to potentially reabsorb water. It increases the permeability of the collecting duct to water. As the water is abstracted, the remaining solutes are progressively concentrated till you get down here to the deepest portion of the inner medulla, where urea can be reabsorbed through UTA1 and UTA3. Now, I'll talk more about this tomorrow at renal grand rounds, but the focus today is going to be on the aquaporin water channels. The urea that is then reabsorbed into the interstitium through the passive mechanism contributes to concentration here in the inner medulla, and is why low-protein diets give you a concentrating defect. Now, you need two things to concentrate the urine. You need, number one, the presence of ADH or vasopressin, because that's critical for moving aquaporins to the apical membrane. You also need a hypertonic interstitium. So if your patient is on a loop diuretic, which will block this transporter, and assuming they're actually compliant with your prescription, they will not be able to produce concentrated urine because there's been no hypertonic medulla here, even though there's ADH and water channels. They also will be unable to produce a dilute urine because you've inhibited both processes at once. So a very quick way to tell if your patient is actually compliant with the loop diuretic is to check urine osmolality, or at least specific gravity, because they should be making isosmotic urine if they're taking the loop diuretic. Now, there are a number of water channels or aquaporins in the kidney. There's actually now 13 cloned aquaporins. The ones that are important for the discussion today are shown here. Aquaporin 1 and aquaporin 7 are here in the proximal tubule and the thin descending limb. Aquaporin 1 is the major form, but there's also some aquaporin 7 that overlaps with it. The key one is shown here in yellow font, which is aquaporin 2. It's present through the entire collecting duct in the apical plasma membrane. And this is the form that vasopressin causes to become active. Aquaporins 3 and 4 are in various portions of the collecting duct in the basolateral membrane, providing a pathway for transepithelial water reabsorption. Now, this is what the aquaporins actually look like. This is work from Peter Agre's group. Peter Agre first cloned the water channels in the early 90s, and that cloning of aquaporin 1 won him the Nobel Prize in Chemistry in 2003, and we actually were honored to have him as one of our plenary speakers at the ASN in 2004. So this is from Peter's work, and this is the so-called hourglass model of what a water channel looks like. All the aquaporins have the same basic structure. They're all 6 transmembrane spanning proteins, and then they have these 2 loops, so B and E, that fold back into the membrane like this, and that's why it's called an hourglass model. And these amino acids, N, P, and A, from the 2 loops form a channel that the water actually goes through this hole. There's a cysteine here. For the older, I learned this morning that Jesse likes to give some history at the start of Medicine Grand Round. So My little bit of history is that those of you who have gray hair like me may remember Mercurial Diuretics. I'm sure the residents have never heard of these things and think we'd be poisoning our patients, which wasn't far from the truth. But mercury works on this cysteine. It would inhibit the cysteine and prevent the movement of water through the aquaporin. If you take the cysteine out, then mercurials don't do anything. In the membrane, you get these four aquaporins that exist as a homotetramer, and you need this structure to get the water to go through, even though each individual channel conducts water, and at least one of the tetramer has to be glycosylated. Now, we've been talking a lot about vasopressin. There are actually two types of vasopressin receptors. The one that we're interested in today is the V2 receptor. This makes the collecting duct permeable to water. It's a G protein coupled 7 transmembrane spanning receptor, and the second messenger is cyclic AMP. The one that you're probably more familiar with is the V1 receptor. Is when you use vasopressin in the ICU setting to support blood pressure, what you're really working on is to stimulate the V1 receptor. There are two subtypes. They say it increases blood pressure. It's in vasculature, liver, and brain, and works through intracellular calcium. But for today, it's the V2 that's the main player. So how does water move across a cell? Vasopressin, to orient you, this is a collecting duct cell. This is the tubular lumen, or what will become urine. This is the interstitial or blood side. Vasopressin comes through the blood, binds to the V2 receptor, activates adenylyl cyclase, increases cyclic AMP, which then activates protein kinase A, which then phosphorylates an aquaporin 2 molecule, helps it move to the apical membrane, and when the stimulus when the vasopressin signal is gone, then the aquaporin 2 is endocytosed back into subapical vesicles, where it waits for the next signal from vasopressin to become rephosphorylated and move back into the apical membrane. So it doesn't get degraded. In general, it doesn't fall off into the urine, but they're recycled. It's actually very ecologically sound. Our body is recycling our water channels. Water then can move through aquaporin 2 and exit through aquaporin 3 or 4 as long as there's an osmotic gradient to drive water reabsorption. There is no active transport of water, so you have to have the gradient. Now, is there any proof to this? In fact, there is. What I just articulated, minus the actual names of the water channels, was first proposed in the late 1970s by Jim Wade and Bill Kachadorian, but the proof awaited another 2 decades until the mid-90s when Mark Knepper and his colleagues did this experiment to actually prove that what I just showed you is the case. So what you're looking at here, this is an electron micrograph of the apical and subapical portion of an actual intermedullary collecting duct from a rat perfused in vitro, and the black dots represent immunogold cytochemistry labeling the water channels. So here is before vasopressin. You can see there are some in the membrane, but most are living in these subapical vesicles. And the really incredible part of this study is that the investigators would first perfuse the tubule, measure water permeability, then harvest the tubule off the pipettes and fix it for electron microscopy. And here's the water measurements that go with it. Pre-vasopressin is quite low. They add vasopressin, and I think even in the back of the room, you can see that it's different. And with the aid of the arrows, you can see that all the black dots, or at least the vast majority, are sitting now in the apical membrane, very few left in the subapical space. When you remove vasopressin, it goes back to this picture. And you can see the water permeability goes way up with vasopressin, comes back down afterwards. And if you count the number of black dots in the membrane, you can see it shows the same pattern. So this was the first experimental proof of the shuttle hypothesis. Now, the rapid regulation of aquaporin 2 is actually in 2 different ways. What we just discussed with the shuttle hypothesis is the rapid regulation by vasopressin. That is, it stimulates the insertion of aquaporin 2 vesicles into the collecting duct apical membrane and the phosphorylation of aquaporin 2. But there are also long-term changes. That is, over time, there are increases in the protein abundance of aquaporin 2, and these can be both vasopressin dependent and independent. And this, again, we'll start with some experimental data in an animal. This is from a Brattleboro rat. Now, for those who most of you probably aren't familiar with the Brattleboro rat. This is a rat that was discovered in Brattleboro, Vermont, and that's how it got its name by Heinz Walton. And it's a spontaneous mutation. These rats have central diabetes insipidus. They're unable to make and secrete vasopressin. When you look in their kidneys, and I don't quite know how Heinz found them. Maybe it was the trail of yellow they leave in the snow as they go along. But in any case, this is immunostaining for aquaporin 2. This is a Brattleboro given only vehicle. You can see virtually no aquaporin 2 protein. When you treat with vasopressin for 3 to 5 days, you now see a lot more staining. And if you blow the picture up, you can also see that most of it's in the apical membrane. And when you count or measure aquaporin 2 expression, you can see it goes up after 3 to 5 days of vasopressin, and water permeability from tubules perfused from the same animals also goes up. So this actually shows you both modes of regulation. There is the long-term effect, the increase in transcription and protein abundance, and at the same time, because you've got the sustained stimulus from vasopressin, it's all in the apical membrane. Now, in fact, we should have known about this anyway. This is a classic study from 1957. So 60 years ago, these investigators, DeWardner and Herxheimer, did this study. Now, there were 2 subjects, DeWardner and Herxheimer. Clinical research back then was people experimented on themselves, and I'm sure they didn't need any IRB approval to do this to themselves. And so they decided they would make themselves primary polydipsic. So if you know there are patients who drink too much water, if you drink more than 10 liters a day, you overwhelm the ability of the kidney to dilute. Kidney can dilute to about 50 milliosmoles, but we can't make and excrete distilled water. So there's a lower limit, and if you drink more than that per day, you can get primary or psychogenic polydipsia. And what DeWardner and Herxheimer did is they did it to themselves. They drank 10 liters a day of water for 11 days. Now, allegedly, somebody just told me this story over the weekend, so I have to share it with you, that these guys, they were in London, and they had 2 big jugs each day. One was the jug they were drinking water from, and the other was the jug that they were putting their urine into, so they could keep track. And they decided they would try to go to a play. Well, by the intermission, they were both in real trouble. So they ran out of the theater across the street to their laboratory, and it was midday, so the volume in the 2 jugs was almost the same. And they weren't sure which jug they were supposed to drink and which one they were supposed to collect their urine in. Don't know if that's true, but that's how they tell the story. At any rate, at the end of the study, they measured urine osmolality after water deprivation or vasopressin. And let's look at the results. So before they did this to themselves, they were making urine of 1,000 to 1,200. They gave each other exogenous vasopressin, and nothing changed. They had already maximally concentrated from their endogenous AVP. However, after all the water drinking, and I guess going to the theater, they were down at around 500, and even with exogenous vasopressin, nothing further happened. So this is classic psychogenic polydipsia in that when you first stop the water drinking, you still can't concentrate, and as we're all been taught, it takes 3 or 4 days till you restore concentrating ability. Now, this suggests, in some of the textbooks, it will claim, and for years it claimed this, that this was just wash out of the medulla. Well, That doesn't make any sense. When you figure 25% of your cardiac output is going to your kidneys, there's more than enough solute going back through the kidneys very quickly to restore concentrating ability. But what it does mean is the kidney is not able to make use of that solute at that point. It's turned off the genes for water channels, for other proteins that are critical, and so you have to turn those genes back on, transcribe them, make the proteins, get them right in the place, and that's why you have the 3 to 4 days. So this study from back then, although none of these molecules were known, suggested long-term regulation of concentrating ability. Now, to get to the part of the talk that was based on the title, what is nephrogenic diabetes insipidus? These are patients who produce very large quantities of dilute urine due to end organ insensitivity to vasopressin. Most cases, and probably almost all that we see in adult medicine, are acquired, almost always due to chronic lithium use, although other medications can also cause it. But there are also hereditary cases. These are about 10% of all cases, and 90% result from mutations in the V2 receptor. Most of the other 10% are mutations in the aquaporin 2 water channel. And with our understanding now of how water is reabsorbed, these genetic causes make perfect sense. If you don't have a functional V2 receptor, you've got no way to respond to vasopressin, and that would give you end organ insensitivity. On the other hand, if you have everything else is fine, but your water channel itself is mutant, you're in real trouble because there's still no machinery there to reabsorb the water. The V2 receptor mutations are an X-linked form of inheritance, obviously, whereas the rarer aquaporin 2 forms are due to, can either be autosomal recessive or autosomal dominant. Now, again, this makes, if we think about our cell, if vasopressin tries to bind to a mutant receptor, nothing of the rest of the downstream pathway can actually happen. Same thing, if aquaporin 2 is mutant, then all this can happen, but there's nothing to put into the membrane. This is not a complete showing of where the mutations are. This is a V2 receptor, a 7-transmembrane spanning protein. Each of these red circles is an amino acid that is mutated in some family with X-linked nephrogenic DI. So unfortunately, this means you can't develop a simple genetic screening test. You actually have to know in every family what the mutation is in order to screen at-risk infants. This is particularly important since if you look at the literature from the 1980s, it says mental retardation is part of the syndrome of nephrogenic DI. In the early 90s, when these proteins were cloned and people started screening at-risk infants, in this case at-risk boys, and treating them with water, simply water, to prevent repeated bouts of dehydration, the boys were fine neurologically. I've met some who are in college now. So it was a preventable form of mental retardation that was secondary to repeated bouts of dehydration. Now, I have no idea why boys in at-risk families, if they were polyuric, weren't treated with water before the genetics were worked out. That was before my time, fortunately, but it's very preventable and treatable. This is an aquaporin 2, and again, each red circle is where a different family has a mutation. So again, you have to look at each family to work out the genetics. So in adult medicine, most of the NDI we see is acquired. It's due to lithium. And what does lithium do? It inhibits adenylyl cyclase, so that even though vasopressin can bind to the receptor, the activation of adenylyl cyclase is markedly suppressed by lithium. You don't get cyclic AMP, and the rest of the downstream cascade cannot happen. Lithium doesn't necessarily 100% inhibit adenylyl cyclase, but it does it by several orders of magnitude, so you get very little of an effect. So This is a study from my group. Mitzi Blunt was the first author on this study, and she did this in rats and treated them with lithium. And it brings up an important point. So here's aquaporin-2 protein by Western blot. It's a glycosylated band from about 35 to 50 kilodaltons with a non-glycosylated band at around 28, 29. So these are normal rats. These are rats treated with lithium for 7 days. You can see the amount of protein is going down. By 14 days, you almost can't see the aquaporin-2 anymore. 14 days of lithium. And this is at lithium levels that are in the low therapeutic range, like 0.7. This is not toxic lithium. You stop the lithium, and you see aquaporin-2 beginning to recover, but it doesn't recover to control levels. Even 2 weeks after stopping the lithium, it's only at about 50%. And very commonly, the effects of lithium don't reverse when you stop the drug. So patients who develop lithium-induced NDI, once they get it, it's not going to go away if you simply stop the lithium in most cases. Here's another example of the effect of an acquired form of NDI. This is hypokalemia. This is from David Marple's group. Here's a control rat. The green is aquaporin-2 by immunofluorescence in the collecting duct. Here's the immunohistochemistry. You make the rat hypokalemic, for in this case for about 10 or 11 days, and you can see much less aquaporin-2 protein, either by the imaging or by Western blot. And another example, again from our group in collaboration with Bill Harris, looked at 3 to 4 days of hypercalcemia. This was calcium levels of around 12.5 to 13 in these rats. You can see that compared to control, there's less aquaporin-2 in the hypercalcemic rats. You can see it more easily by protein. And when we measured the water permeability to these animals, here's the normal animal with a nice response to vasopressin, and even more with a higher dose of vasopressin, and no effect of vasopressin to increase water permeability in the hypercalcemic rats. So acquired NDI, whether lithium, hypokalemia, or hypercalcemia, all result in a decrease in aquaporin-2 protein and water permeability in the collecting duct, which will decrease water reabsorption even in the presence of vasopressin, resulting in nephrogenic DI. Now, fortunately, if you correct the electrolyte abnormalities, you can reverse the process. As I mentioned, the lithium process is generally irreversible. So, how have physician scientists and research scientists used this knowledge to come up with new strategies for treating nephrogenic DI? And I'm going to, over the most of the rest of the talk, or the next portion anyway, review a number of advances. These 7 treatments here all have some been used, and I'll show you the data that exists. So the first study, and I should back up and say the concept here is if you have NDI due to V2 receptor mutations or due to lithium, your water channel is still fine. So if you can get around the roadblock, you could potentially find another way to get your water channel activated and reabsorb water. None of these will work if it's your water channel itself that's mutant. Probably that'll await the day when CRISPR-Cas technology can really be used in people. But if everything else is fine, it's like having you've got a big traffic accident on the highway. If you can get around it on side streets and get back on the highway, you're okay. And that's kind of the thinking. And really the credit for the first study taking this approach was this paper from Dennis Brown's group in which they used sildenafil. Now, I'm sure anyone who watches sports, I'm sure any Louisville Cardinal game has many commercials for sildenafil and its related compounds. But sildenafil activates cyclic G, not cyclic A. And Dennis's group looked at the question of whether cyclic G could maybe do some of the effects through that cyclic A did. And so here is a tubule in this case, a Brattleboro rat. You can see the aquaporin 2 is not in the membrane. He gave DDAVP to the rat, and you see it in the membrane, and he also gave them sildenafil, and it's not bad. In fact, when you look at the average values, here's control, here's sildenafil, here's vasopressin. Not quite as good, but still a big improvement over control. The problem with sildenafil, not by the people who sell it, but the problem for this application is it increases blood flow. And so while there's more aquaporin 2 in the membrane, you've also increased renal blood flow, which tends to decrease concentrating ability. So the rats actually didn't have any net gain in urine concentrating ability. But this was proof of concept that one should think about other ways to get aquaporin 2 into the membrane. Now, this paper came out not quite 2 years ago, and actually somebody based on Dennis's studies did this work. This is a single case report, 4-year-old boy with X-linked NDI resistant to conventional therapy, which is hydrochlorothiazide and a nonsteroidal, and was treated with sildenafil for 10 days. And sildenafil did reduce 24-hour urine volume, dropped it almost in half, and reduced serum sodium and increased urine osmolality. So this is one case, patient studied outside the U.S., but it suggests that, in fact, the sildenafil approach, despite the rat not improving, may actually have some merit in at least some cases. This is another study from Dennis Brown's group, in this case using simvastatin. You're all familiar with simvastatin. He used it to change the cholesterol content of the membrane. And he found that it enhanced aquaporin 2 expression and reduced urine output, again in the Brattleboro rat. So these are 3 control rats. These are 3 rats given simvastatin. And as Dennis likes to say, it's pretty obvious that there's less urine in the bottles over here than over here, suggesting a benefit in terms of concentrating ability by changing the cholesterol content of the membrane. The problem is it wears off fairly quickly. So this is the time course. It's probably a little hard to see, but this is 1, 2, 4, 5, and 12 hours. And while you get a nice increase in urine osmolality in the first few hours, by 12 hours the effect is gone. So it was true, but it wasn't sustained. And if you look in the kidneys of rats, you can see control and simvastatin. The apical staining is much stronger in the both cortex and outer medulla for aquaporin 2. Now, again, but based on this study, people began to look at human data and ask the question of what happens to concentrating ability in patients who we give statins. So this was a study from Italy, published just last year, in which they looked back at 24, it's retrospective, 24 naive hypercholesterolemic patients. They were able to go back and get urine samples. They measured the excretion of aquaporin 2 at baseline and during their first 12 weeks of treatment with simvastatin, and it did induce a rapid and significant increase of urine aquaporin 2, reduced the 24-hour diuresis, and increased urine osmolality. And then they were able to follow these patients, and they said the effects were maintained for at least a year. So these are normal patients given simvastatin for hypercholesterolemia, but at least it is suggestive that perhaps simvastatin could be effective in the treatment of NDI. Another approach was taken by Daniel Bichet's group in Montreal, and they explored the concept of chaperone therapy. Now, I know the pulmonologists are all going to be familiar with chaperone therapy, as this has been explored particularly for cystic fibrosis. And the concept is that sometimes you make proteins that are mutant, and the endoplasmic reticulum's job is to check those proteins, and if they're mutant, you're supposed to destroy them, and that's what the ER does. It does it very well. But some of these proteins, like in the CF literature, the delta 508 mutation, if you could get them to the membrane, if you could get the ER to stop degrading them, and you get them to the membrane, you actually have partial function. And there are now drugs that do this for the CF field. Well, the same is true for some forms of NDI. Some of the V2 receptor mutations are not that bad. Some are very short, truncated forms, but others are fairly good. And when you force them to the membrane, you get partial function. And so Daniel's group explored chaperones that would help get them through the ER without being degraded and get them to the membrane. And that concept is shown here. This is not kidney. These are cultured cells, untreated and treated with this SR compound. You can see that it gets it to the membrane. The problem with this is the only things that work were V2 receptor antagonists, as SR is here. So yes, you could use a receptor antagonist to get the mutant V2R to the membrane, but it was inhibiting it when it got there. And when he tried V1 receptor antagonists and other compounds, they didn't work. So again, the proof of concept that you can do it, but unfortunately it's not going to move forward unless you could knock the inhibitor off. Another compound, again, this is from Dennis Brown's work, published just in October of 2016, involved the use of erlotinib. And I'm sure the hem-onc folks are familiar with erlotinib. It's used as a chemotherapeutic agent. It's a selective inhibitor of the EGFR. It does increase aquaporin-2 expression in the collecting duct and reduce urine volume by nearly 50% in mice with lithium-induced NDI. But as the oncologists know, there are a lot of side effects with the use of erlotinib. And while it's appropriate to treat cancers, it probably is too toxic to put people on lifetime therapy for nephrogenic DI. Another compound that's been looked at doesn't even have a real name. It's this ONO, whatever. So the ONO compound increases urine osmolality in congenital NDI. This is a mouse model. It's an inducible V2R knockout. So you make the mouse and you feed it tamoxifen to knock out the V2R, and then you treat the animal with this ONO compound. What is ONO? The concept here was to stimulate another GS-coupled receptor that activates pKa. So even though the V2R is mutant, if you have another receptor that can also work through the same second messenger, perhaps you could get a beneficial effect. And so ONO activates the EP4 prostanoid receptor. This in turn increases the prorenin and prorenin receptor to increase aquaporin-2 protein in the collecting duct. And ONO does increase urine osmolality in these V2R knockout mice, greatest effect at 1 day, and then it begins to peter out. The real problem here is that ONO has very limited solubility and is actually fairly unstable in aqueous solution, so that until the medicinal chemists can come up with a better, more stable version of this ONO compound, it's not going to move forward. But again, another proof of concept of a strategy of trying to think about how to treat the disease. Another recent paper used clopidogrel. And again, many of you, I'm sure the cardiologists in particular, are very familiar with clopidogrel. This is a P2Y12 receptor, signals through GI to decrease cyclic AMP, whereas clopidogrel is a selective inhibitor, so that it actually results in an increase in cyclic AMP. And in lithium-fed rats, clopidogrel reduced polyuria and decreased urine osmolality, and it increased aquaporin-2 abundance. So P2Y12 blockade with clopidogrel increases vasopressin-stimulated cyclic AMP production, and this could be a therapy for lithium-induced NDI. Clopidogrel is on the market. It's very safe, as you know, an antiplatelet agent. And it could work for lithium-induced NDI. It won't work for congenital NDI because it's attacking a different part of the pathway. In the V2R mutant, there's no cyclic AMP to amplify, whereas in the lithium model, as I mentioned, it inhibits adenylyl cyclase, but it doesn't do it by 100%. So by amplifying the cyclic A that's there with clopidogrel, you may see a nice benefit in your lithium NDI patient. But this has not been studied in people, although it's sort of crying out for that next study. Work from our group that was published last year used another agent that you're all very familiar with, metformin. Metformin activates AMP kinase, an enzyme involved in cellular energy balance, and it had been reported that AMP kinase can stimulate NKCC2 independent of vasopressin. And recall, NKCC2 was that critical protein that led to the hypertonic medulla. And so we tested it, and we found that AMP kinase can activate both the water channel as well as a urea transporter independent of vasopressin. And here are some data that we published last summer in which we made a rat model of NDI. What we did is we took rats and we treated them with tolvaptan. Again, many of you have probably used tolvaptan to treat osmolality, hyponatremia. So tolvaptan binds to the V2 receptor and gives us sort of a chemical knockout of the V2R. Then half the animals were also given metformin. And let me walk you through this slide. So here's normal rats. They make urine osmolality up here, almost 2,000 in this case. We give all the animals tolvaptan only for days 2 through 5. And you can see it drops their osmolality by about 50%. Starting on day 6, half the animals stay on tolvaptan alone, and these are the light-colored bars. The other half start getting metformin once a day. The light-colored bars stay stable out to day 14. So sustained tolvaptan therapy, as you all know, is highly effective. When you give the metformin, within a day, it comes up essentially to control levels, and it stays up there for the next week or so. So this is very exciting because metformin is well tolerated, it's safe, it's commercially available, it's dirt cheap. In fact, in Atlanta, you go to the Publix with a prescription and you get it for free. They hope you'll do your food shopping while you're waiting for them to count out your pills, but regardless, it's free. And it's sustained. So if you're going to treat a congenital condition, getting a 3, 4, 5 hour improvement that goes back down where you started from doesn't really do the patient any good. So at least out to a week or 2 weeks in these rats, we didn't see tachyphylaxis, we didn't see a wearing off of the effect. And so I think this really is, to us, very exciting. So in the final little portion of the talk, I want to come back to some other common clinical conditions that you're probably used to seeing and show you the role of aquaporins. So the first is congestive heart failure. The model is left coronary artery ligation. Now, believe it or not, you can tie off the LAD in a rat. It doesn't die. I'm not quite sure why, but they do pretty well. And their LVEDP does increase, though, from 4 to 27. They get hypoosmolality, and their plasma vasopressin goes from 3 to 11. So this is a classic non-osmotic release of vasopressin. You induce congestive heart failure in the animal. They get hyponatremia, and they get elevated vasopressin. What happens to the water channels? Well, they do exactly what they should do in response to vasopressin. So this is a study from Mark Knepper's group. Here you can see a control animal. Here you can see an animal who has congestive heart failure. You can see that all the aquaporin 2 now has moved primarily from here it's both in the membrane and intracellular. Now it's virtually all at the membrane. If you look by Western blot, you can see an increase in protein abundance. So the two things we talked about vasopressin doing, increasing aquaporin 2 abundance and moving it to the membrane, happens in heart failure. And that fits with our classic teaching that the kidney responds to heart failure the way it would to true volume depletion. The kidney doesn't know what the cause of the hypoperfusion is and responds in its normal fashion. Unfortunately, in heart failure, that's not helping the patient. Bob Schreier's group took this one step further. They added a V2 receptor antagonist and showed here's aquaporin 2 protein, goes up in heart failure in rats, and when you give a V2R, it comes back down to control levels, suggesting that inhibition of the V2 receptor should be useful for correcting hyponatremia and heart failure. And in fact, studies would corroborate this, but as you know, using chronic V2R therapy is very expensive. So heart failure, increase in vasopressin leads to increases in aquaporin 2 protein and trafficking, and the V2R is responsible. What about ureteral obstruction? We've probably all seen many patients with this. These are rat studies from Jørgen Frokier's group in Denmark. They have done both unilateral and bilateral obstruction. The rats develop, as people do, a post-obstructive diuresis when you release the obstruction, and free water clearance is reduced. What happens in the kidney? Well, let's look first at the bottom panel at urine output. Clear bars are the sham-operated animals. The solids are the bilateral obstruction. At 24 hours, of course, the shams are making urine and the bilateral obstructeds are not. You release it for 24, 48, or 7 hours or 7 days. The sham stays stable. You get a post-obstructive diuresis at 24, a little better at 48. And by 7 days, it's back down to normal. And this is what we see in patients as well. You release the obstruction, they get a post-obstructive diuresis, and eventually, and it does recover. But look at the aquaporin 2 in these kidneys. Again, the shams are stable, they're set to 100%. In the obstructed kidneys, it's down to 25%. It's still at 25% at a day, still there at 48 hours, even though urine output's begun to recover. And even at a week, it's only at 50%, even though urine output has normalized. And this really helps to explain the clinical finding that post-obstructive diuresis, these patients are at great risk of volume depletion. And even when urine output has normalized, their kidney has not completely healed. So one must be very careful in that period after release of obstruction to avoid any volume depletion or any other insults to the kidney, and not to be fooled by the fact that urine output is normal and think that everything is fine. And so I really said all that. So we'll turn to the last topic of the talk, which is the kidney in aging. So, as you know, aged individuals are unable to concentrate their urine as well as younger individuals, making older patients more susceptible to hypernatremia. So, in collaboration with Celia Sladek's group, we studied this using 4- and 30-month-old rats. Now, 4-month-old rats are young adult, adolescent, they're probably like late adolescent people. 30-month-old rats are really old rats. Most don't even live much beyond 2 years. So we were able to get these from the National Institute on Aging, and we water restricted them for 3 days. And let's look first at these data. We'll look at the younger animal, hydrated or dehydrated. They lost 8% of body weight. They get hemoconcentrated. They get hypernatremic. And their kidneys are doing a champion job of concentrating the urine. Look at the old animals. They had not quite as much change in body weight. Their hemoconcentration is similar. But look at, despite these similar or slightly less severe changes, their sodium goes up to 163. Much more profound hypernatremia than the younger animals, and it's explained by the fact that they just can't concentrate as well, so they're not able to retain the water. If you look at aquaporin 2 protein abundance, it goes way up in the dehydrated younger animals, and there's actually no statistical change in the older animals. Now, why does this happen? Celia looked in the brain. Both young and old rats had similar pituitary vasopressin stores, but the older rats did not increase plasma vasopressin levels during water restriction. So that this may be the mechanism for the failure of the older rats to increase aquaporin 2. They did not get the increase, despite having lots in the pituitary, they don't get the increase in plasma, and it's thought that, in fact, in aging, you get a combined central and, to some extent, nephrogenic DI. So let's finish with going back to that clinical case that I started with. What can we actually do for this patient? Well, number one, he has to drink enough water to match urine output. Secondly, the conventional therapy is a thiazide diuretic. And for those who are wondering why on earth you give a thiazide diuretic to a polyuric patient, if you can induce a mild volume depletion with the thiazide, you can cause the proximal tubule, instead of reabsorbing 60% of the glomerular ultrafiltrate, to actually reabsorb 80%. Doesn't change anything about osmolality, but it simply reabsorbs more fluid in the proximal tubule. And if there's more reabsorbed, there's less going downstream to potentially become urine. So a thiazide with a mild volume depletion can reduce total urine output. To do this, a patient needs to have a very low sodium diet, 0.5 grams. We can't even get most people to follow a 2-gram sodium diet for heart failure. So this is a very restricted sodium diet. This is a real problem in kids with congenital NDI, who, again, you would do the same 3 things. But, kids go to a birthday party and somebody's got McDonald's French fries. They don't even have to eat the French fries. They can just inhale the salt off the French fries, and they've had that much salt. So it's a real lifestyle problem for the kids. You can give a nonsteroidal, but they're nephrotoxic and they can have GI side effects. You could stop the lithium and use another agent. But as I mentioned, the NDI is often irreversible, and many patients who are well controlled on lithium for their manic depressive disorder really don't want to change their therapy. And it becomes a really awkward situation for the psychiatrist, who often consults Renal and says, what do I do? And, there's not great options. So finally, the cloning of the V2 receptor and aquaporin 2s provide the basis for congenital NDI, and they've also permitted tremendous progress in our understanding of the cellular mechanisms by which vasopressin regulates water reabsorption in the collecting duct. Finally, I've talked about my collaborators as we've gone on. I've been fortunate, as Eleanor said, to be supported for this work through the NIDDK, and I'd be delighted to answer any questions.
Thanks, Jeff. That was great. I'll start off with one question. The world of medicine is moving very much towards genetic testing, for many different disorders. These types of disorders pose a real issue, as you mentioned, because every family has its own personal mutation. Yeah. Is there any place, if we suspect that somebody may have one of these mutations, is there any lab that we can send off?
Yeah. Yes. Daniel Bichet's lab in Montreal will do the genetics of any patient who you think has congenital NDI. And in fact, they do it for free. You only have to pay the cost of shipping the blood to Montreal, and then his lab will genotype the patient, relatives of the patient, and it's all done for free. So I don't know how he can do it. It's the difference of the Canadian system. But yes, that would be the place to go.
Steve?
Unsuspecting health officer doesn't give us enough fluids when they're NPO. Yeah. But there seems to be a tremendous variation in polyuria, at least the clinical and personal quality of life issues. Why is it so variable? Why do some of the patients have really negligible clinical syndromes and others really might have quite profound?
That's an excellent question, of which I don't think there's any answer. It's true both for the NDI, where about half the patients will develop NDI. The severity of the NDI will vary tremendously. Some patients also develop chronic kidney disease, chronic interstitial nephritis from lithium, but not all do. And it doesn't correlate with lithium levels, so it probably has to do with factors that, at least at this point, we don't know. But you're right, some patients do, if they have some NDI and it's not terrible for their quality of life and they really don't have interstitial nephritis or elevated creatinine at least, they're probably happy to continue, but others, it gets very severe but what the genetics of that or the understanding for why there's such variability, I've never seen anything describing that.
Means that if I'm managing SIADH with tolvaptan, that I have to be more cognizant about medication effect on the efficacy of tolvaptan?
I would think so. Certainly for metformin and potentially for some of the other things that we just saw, clopidogrel, simvastatin, sildenafil, I think absolutely you need to, if you have combinations of drugs, to be aware that the tolvaptan you may be counteracting it. I think it's also interesting, there's a classic study in the polycystic kidney disease field in which tolvaptan was used to treat PKD. And I've wondered, in fact, whether, in fact, that the somewhat blunted effects there could have been masked by other drugs that patients were taking. I've tried to get access to the database for that study, but to no avail. So absolutely. That lead to DI, or not the ones that reverse it? Lead to DI. Well, lithium can do, as I say, is the most common. Many of the anti-HIV drugs can do, some of them can do it as well, foscarnet. Most of them will do it by interfering with cyclic AMP metabolism. They don't really interfere, that I'm aware of, with direct effects on either the V2R or the aquaporin 2 water channel. That is not known. The best studied of all of these has been lithium, and why it doesn't reverse. Lithium is sort of a strange molecule, because once lithium gets into cells, it doesn't have a way to get back out of cells. So I think there is just the chronic effect of the lithium. The other medications have really not been very well studied. It's more either anecdotal reports that it's been observed in patients or limited animal data, but the detailed mechanisms of how these other work is not there. We've tried to look at some of these. Some of these are very hard to give to animals, actually. So there's just very little data. I think it's a great question as to what the mechanism is. Are they all the same? But whether, for whatever reason, it just isn't out there.
Okay. Jeff, this was terrific. For our guest speakers, for rounds, we send you home with a Louisville Slugger. You will not be able to take it on the plane. It will be shipped to you. So
Okay.
Congratulations, and thank you for a wonderful talk.
Thank you. Well, that's great. It's spring training, and I love baseball. She is.
Yeah, she was one of our former residents here quite a while ago, obviously. But anyway, if you run into her, tell her that I said hello.
I will definitely do that.
I was the program director here for 15 years, so she was one of my residents.
She's doing very well, in fact.
Yeah.
She's by choice.